Chapter 8 Infection Control. Topic: Post Exposure Prophylaxis. The objective of this video is to apprise the viewer about risk of infection through sharps and importance of prevention of such exposures, standard precautions and safe laboratory practices, steps of post-exposure management, management of individuals exposed to HPV and HCV, and importance of documentation of such exposures.
Post-exposure prophylaxis. Objectives. This video shows various sharps being generated,
occurrence of occupational exposure of healthcare workers to some blood-borne viral pathogens, for example, HIV, hepatitis B virus, and hepatitis C virus.
ways of minimizing or preventing such exposures, need for prompt institution of post-exposure prophylaxis or PEP after such exposure. Sharps being generated in any healthcare setting are of various types. An exposure that may place healthcare professional at risk of blood-borne pathogens is defined as a percutaneous injury, for example, needle stick or cut with a sharp instrument, contact with the mucous membrane of the eye or mouth, contact with non-intact skin, particularly when exposed skin is chapped, abraded, or afflicted with dermatitis, or contact with the intact skin when the contact duration is prolonged, for example, several minutes or more, with blood or other potentially infectious body fluids. Potentially infectious body fluids include blood, blood products, all body fluids, pleural fluid, pericardial fluid, peritoneal fluid, semen, vaginal secretions. The following are not considered potentially infectious unless visibly contaminated with blood: feces, nasal secretions, saliva, sputum, sweat, tears, urine, and vomitus. Transmission through intact skin has not been documented. Factors that influence risk of infection are type of needle, hollow bore versus solid, device visibly contaminated with patient's blood, depth of injury, the amount of blood involved in the exposure, the amount of virus or viral load in the exposed body or body fluid at the time of exposure, timely availability and efficacy of PEP. Steps for post-exposure management. These are the steps to be followed after accidental exposure to blood or other potentially infectious materials. 1. First aid. 2. Risk assessment. 3. Informed consent and counseling. 4. Decision on prophylactic treatment for HIV and HPV. 5. Monitoring and follow-up of HIV, HPV, and HCV status. 6. Documentation and recording of exposure. 1. First aid. A. Management of exposed site for skin. If the skin is broken after a needle stick or sharp instrument, immediately wash the wound and surrounding skin with water and soap and rinse. Do not scrub. Do not use antiseptics or skin washes, for example, bleach, chlorine, or alcohol. B. For the eye. Immediately irrigate the exposed eye thoroughly with water or normal saline. If wearing contact lenses, leave them in place while irrigating. Once the eye is cleaned, remove the contact lenses and clean them in a normal manner. Do not use soap or disinfectant on the eye. C. For mouth. Spit fluid out immediately. Rinse the mouth thoroughly using water or saline and spit again. Repeat the process several times. Do not use soap or disinfectant in the mouth. The exposure must be reported immediately to the concerned authority so that, if required, prophylaxis can be started as soon as possible. Consult the nearest resource or ART center for PEP, evaluation and follow-up as per the national guidelines on PEP. Assessment of infection risk. A designated person or trained doctor must assess the risk of HIV and HPV transmission following an accidental exposure to blood, or the AEB. This assessment must be quick so as to start treatment or prophylaxis without delay. Assessing the nature of exposure. 3 categories are described based on the amount of blood or body fluid and the entry port. These categories are intended to help in assessing the severity of the exposure but may not cover all the possibilities. Category: mild exposure. Definition and example: mucous membrane or non-intact skin with small volume. For example, a superficial wound, that is, erosion of the epidermis, with a plain or low caliber needle, contact with the eyes or mucous membrane, subcutaneous injuries following a small bore needle. Moderate exposure. Definition and example: mucous membrane or non-intact skin with large volumes or percutaneous superficial exposure with solid needle. For example, a cut or needle stick injury penetrating gloves. Severe exposure. Definition and example: percutaneous with large volume, for example, an accident with white bore needle, visibly contaminated with blood, a deep wound, hemorrhagic wound and or very painful, transmission of a significant volume of blood, an accidental injury with material which has been previously used intravenously or intraarterially. Assessing the HIV status of the source of exposure. Evaluation of the source. If the HIV status of the source person is known and confirmed as negative, PEP is not required. If the status of the patient is unknown and neither the patient nor his or her blood is available for testing, then the choice of whether to use PEP and what regimen will depend on the severity of the wound and how much is known about the individual's HIV risk history. If the status of the patient is unknown and the patient is available, he is to be counseled and consent obtained for testing. If the patient refuses testing but a sample of blood is available, it is the right of the exposed person that the blood sample be tested, but the source patient may decline to be informed of the result. If the patient has refused counseling and testing and there is no blood sample available, it is the right of the exposed person to ask that blood be taken for testing, and the source patient may decline to be informed of the result. Under no circumstances should the source patient be charged for the test. If the patient is known to be HIV positive, evaluation of risk is in order. 2 key factors to consider are antiretroviral drug naive, whether he or she is on ARTs, and whether the patient is likely to have a high viral load as determined by testing, if available, or by clinical signs and symptoms. Low risk, asymptomatic or viral load is less than 400 copies per ml. High risk, symptomatic with OI or AIDS, acute seroconversion, high viral load. In the case of a high-risk exposure from a source patient on ARTs, consult an expert to choose appropriate PEP regimen if drug resistance is high. HIV status of the source. HIV negative. Definition of risk in source. Source is not HIV infected, but consider HPV and HCV. Low risk. Definition of risk in source. HIV positive and clinically asymptomatic. High risk. Definition of risk in source. HIV positive and clinically symptomatic. If the HIV status of the source is unknown, Definition risk in source. Status of the patient is unknown, and neither the patient nor his or her blood is available for testing. Informed consent and counseling. Almost every person feels anxious after exposure. They should be counseled and psychological support provided. They should be informed about the PEP. Exposed persons should receive appropriate information about the risks and benefits of PEP medications. It should be clear that PEP is not mandatory. Exposed persons should, however, be made to understand that a few cases of transmission have been seen in cases given by prophylaxis. Documentation of exposure is essential. For prophylactic treatment, the exposed person must sign a consent form. Informed consent also means that if exposed, the person has been advised on PEP. If the individual refuses to initiate PEP, it should be documented. The designated officer for PEP should keep this document. An information sheet covering the PEP and the biological follow-up after any AEB must be given to the person under treatment. Decision on PEP medications or regimen. Because PEP has its greatest effect if started within 2 hours of exposure, it is essential to act immediately. Ideally, therapy should be started within 2 hours and definitely within 72 hours of exposure. Never delay starting therapy due to uncertainty. Reevaluation of the exposed person should be considered within 72 hours post-exposure, especially if additional information about the exposure or source person becomes available. If the risk is insignificant, PEP could be discontinued if already started. Exposed individuals who are known or discovered to be HIV positive should not receive PEP.
The basic thing that needs to be understood is that any suspected HIV exposure through needle, the answer lies in PEP and within 72 hours or 3 days. That's the main thing.
The decision to start this type of regimen depends on the type of exposure and the HIV status of the source person mentioned earlier. Dosages of the drugs for PEP for adults and adolescents. Fixed dose combination FDC of tenofovir, that is TDF, 300 mg plus lamivudine 3TC 300 mg plus efavirenz EFV 600 mg once daily for 4 weeks. If the source is already on ART, start the exposed person with the above mentioned regimen at the earliest with proper counseling and then refer for an expert opinion. Seek an expert opinion in case of delay in reporting exposure more than 72 hours, unknown source, known or suspected pregnancy, but initiate PEP, breastfeeding mothers, but initiate PEP, source patient is on ARTs, major toxicity of PEP. Pregnancy and PEP. If the concerned healthcare professional is pregnant at the time of occupational exposure to HIV, she should get regimen for primary management of the exposure like non-pregnant persons. Pregnant women who sustain occupational exposure should also be offered antiretroviral chemoprophylaxis if required. The designated authority or physician must be consulted about the use of ARTs for post-exposure management. For a female healthcare professional, considering PEP pregnancy test is recommended in case of a doubt. Post-exposure prophylaxis against HPV and HCV. Post-exposure prophylaxis regimens against HPV depend upon the HPV status of the source, type of exposure, and previous immunization status of the exposed person. Management of individuals exposed to HPV and HCV. There is no PEP regimen recommended for HCV. However, there are specific steps that can be taken to reduce the risk of infection for those exposed to HPV. Post-exposure prophylaxis for HPV. A person's response to HPV exposure depends on his or her immune status. as determined by the history of hepatitis B vaccination and vaccine response if tested 1 to 2 months after vaccination, and whether the exposure poses a risk of infection. HBV PEP is safe for women who are pregnant or breastfeeding. Monitoring and follow-up of HIV, HBV, and HCV status. Follow-up of exposed healthcare professionals. Long-term follow-up, counseling, and education. Testing for at least 6 months after exposure, that is 6 weeks, 12 weeks, and 6 months. HPV immune status. Unvaccinated, post-exposure prophylaxis, HBV vaccination, and HBIG. Previously vaccinated, known responder, anti-hepatitis B surface antigen positive, post-exposure prophylaxis, none. Previously vaccinated, known non-responder, HPV vaccination, and HBIG. Antibody response unknown. Test if any antibody response is less than 10 international units per ml. Post-exposure prophylaxis, HPV vaccination, and HBIG. The person should be provided with pre-test counseling and PEP should be started as discussed. Before starting PEP, 3 to 5 ml of the person's baseline blood sample is to be taken and sent to the laboratory for testing and storage. It is important that a serum sample is collected from the healthcare professional as soon as possible at 0 hour after exposure for HIV testing. Otherwise, it may be difficult to attribute the infection acquired due to exposure in the occupational setting. This may have a bearing on the claims for compensation from the health authorities. The first sample for HIV testing is collected immediately after exposure, the second at 6 weeks, the third at 12 weeks, and the last at 6 months after exposure. During the follow-up period, especially the first 6 to 12 weeks, the following measures are to be adopted by the healthcare professional. Refraining from blood, semen, organ donation, and abstinence from sexual intercourse. In case sexual intercourse is undertaken, a latex condom must be used to reduce the risk of HIV transmission. Women should not breastfeed their infants. The exposed person is advised to seek medical evaluation for any febrile illness that occurs within 12 weeks of exposure. Timing: baseline, month 3, month 6, test done irrespective of PEP intake. HIV, anti-HCV, and HPSAG. Documentation and recording of exposure. The exposure report details should include date, time, and place of exposure, type of procedure done, type of exposure, that is, percutaneous, mucous membrane, etc., duration of exposure, exposure source and volume, type of specimen involved. All persons at risk must be informed of the importance of immediate exposure reporting to ensure preventive care can be initiated in time to be effective, and to remember that a casual approach leads to casualty. Occupational exposure and rights of the exposed persons. If transmission of a bloodborne infection occurs after occupational exposure has been documented, the healthcare professional has a right to receive treatment and care for this illness. It is also the right of all infected patients to be free from discrimination at their workplace. Such patients are entitled to have all their human rights respected, beginning firstly with the right to confidentiality regarding their healthcare. Do's and don'ts for the exposed individual. Don'ts. Do not panic. Do not place the pricked finger into the mouth reflexively. Do not squeeze blood from the wound. Do not use bleach, alcohol, iodine, antiseptic, detergent, etc. Do's: stay calm. Remove gloves if appropriate. Wash exposed site thoroughly with running water and soap. Irrigate thoroughly with water if splashes have gone into the eyes or mouth. Consult the designated physician or personnel immediately as per institutional guidelines for management of the occupational exposure.
Question number 1. Your finger has been exposed to a needle stick injury. Out of the following, what should you do next? Option A, panic. Option B, put your finger in your mouth. Option C, wash with liberal amounts of water and soap. Option D, clean with spirit. The correct answer is option C, wash with liberal amounts of water and soap. Panicking around can only lead to wastage of time, and time is of essence in post exposure prophylaxis. Putting your finger in your mouth is not recommended. Cleaning with spirit adds to the irritation of the surrounding skin and can lead to further penetration of the virus. Question number 2. A needle stick injury exposes the individual to option A, HIV, hepatitis A and hepatitis E. Option B, HIV, hepatitis B and dengue. Option C, HIV, hepatitis B and hepatitis C. Option D, none of the above. The correct answer is option C, HIV, hepatitis B and hepatitis C. Question number 3. The chances of acquiring HIV infection through a single HIV infected needle stick injury are option A 100%, option B 25%, option C 75%, option D less than 1%. The correct answer is less than 1%. Question number 4. The minimum protective levels of anti-HBs titers in individuals vaccinated against hepatitis B virus is option A, more than 5 international units per ml. Option B, more than 1 international unit per ml. Option C, more than 10 international units per ml. Option D, everybody vaccinated is protected against hepatitis B. The correct answer is option C, more than 10 international units per ml.